everyone, all the speakers, faculty, and the participants on behalf of GMCH 32 Chandigarh and IPHA for this community geriatric series. So just waiting. We are sorry. We are just getting a little delayed. So we're just waiting for Dr. Sanghmitra Ghosh to join in so that, she can start with. So till now, till that, I'll request if Dr. Pooja is there. She can connect with Mr. Shovik and ma'am and Dr. Kaushik also. So good afternoon, Dr. Runanshu. I can see you. You've already joined. And
good morning, ma'am. Good morning. Oh,
yeah.
sorry, it's a good afternoon. Yeah.
So it's fine. So we're just because struggling since morning. So what do you suggest? We can just wait for 5 minutes, I think, sir.
Yeah, sure. It's fine for me.
Right,
it's fine.
sir. So I think I'll just try to connect to ma'am again if she's there, and then I'll be just on the board again. And today, this is the series we have started, and all the participants, I just want to tell them that we'll be inviting many speakers, and Dr. Runanshu, of course, he's a renowned speaker and is a renowned geriatrician in India, and he has many of the collaborations with the US and other countries. And we have a series of 4 to 5 these webinars, and in the end of that we'll be all giving you the e-certificates that will be from the IPHA basically. So we already had one webinar, and that was on the common mistakes that a physician or a primary care physician they commit while examining the elderly. Today we are here to deal with a very important aspect, and that is the polypharmacy and deprescribing in elderly. And we all know that it's a quite prevalent practice of polypharmacy in India. So before I delve into more, I'll just try to connect with ma'am once again.
अबे ये फोन बड़ा कैसे होता है मेरी
I've already conveyed to ma'am and Dr. Kaushik, the president and the secretary of the IPHA. So they'll be joining soon. So I think till that, we can just start with our session. So I'll just request Dr. Pooja. Achha, ma'am has already joined.
Hello.
So I request ma'am to kindly take over.
Everybody is
With us, we have Dr. Sanghmitra Ghosh, and she is the president of IPHA. So I would request ma'am to please say a few words about this series and about this topic, and then we can go ahead. Ma'am, please.
Hello. Good afternoon, everybody. I'm sorry,
Good afternoon, ma'am.
I'm little late because I'm not in a very good network area now in Pune. It is a marvelous project and which we have taken with Dr. Sania that we'll have geriatric sessions for series of sessions actually in the next few months. And our first speaker, Dr. Arunanshu Talukdar. He is very well known in geriatric medicine. And I think introduction will be given by Dr. Sonia. I welcome you all to this joint endeavor of this geriatric session. I request all of you who are not member of IPHA to be member of IPHA, because then you will be getting more course, more IPHA related, public health related sessions, and which will be actually for only for the members. So this is more or less awareness program for everybody. Uh, I'm not sparing any time for this. Uh, Over to Dr. Sonia and our speaker, Dr. Arunanshu Talukdar.
Okay, thank you,
Thank-
ma'am. Thanks for this brief and joining us. Uh, I really welcome Dr. Arunanshu, but before he takes over for this talk, I'll be just briefing you a little bit about the polypharmacy. So, Dr. Pooja, can you start with that so that we... Okay. So, Dr. Pooja, I think the screen is not properly shared. It is overlapping. So
Dr.
can you...
Sonia,
Yes, ma'am.
I'm just interrupting. Can you please
Yes,
do introduce Dr. Arunanshu and let him speak, because there is very less time.
okay, ma'am, I'm just covering for 5 minutes. Then I'll be introducing sir because sir has a big talk. So just for five
Yeah.
minutes, I'll be just telling. Okay.
Okay.
So this is, I'll be just telling about the polypharmacy. So polypharmacy is that WHO has predicted that number of older people worldwide will reach to 1.5 billion by 2050. And this population growth poses significant challenges for healthcare systems as older people use a disproportionate amount of healthcare resources. And its prevalence is approximately 40 to 45%. The polypharmacy is there globally. And in Indian scenario, it is 55 to 60%. Next slide, Pooja. So what is polypharmacy basically? Polypharmacy is the use of 5 or more pills that includes over-the-counter prescription and traditional and the complementary medications, many of which may be clinically inappropriate. And the hyperpolypharmacy is use of 10 or more pills. And the pill burden is the number of the pills which all patients they are taking. And they can be in the form of the capsules or it can be tablets. And along with that, the patient also takes the extra efforts to to store or organize them. Next slide. So there are two types of polypharmacy, that is the appropriate polypharmacy and the inappropriate polypharmacy. And the appropriate polypharmacy is called as the therapeutic polypharmacy and the inappropriate is called as the contra-therapeutic polypharmacy. That is the irrational use of drugs. So what are the reasons basically? The reasons are basically that in elderly, we have the physiological changes also, which are age related, and they are by majority of the primary care physicians, they are taken as to be disease things. And other than that, they also have the many comorbidities. So that leads to overuse of many drugs. Next slide. So we can skip that. Next slide. So which is the high-risk population? That is the increasing age, hemodynamically unstable patients, low body weight, females, 6 or more chronic disease states, and the history of the adverse drug reactions. Next slide. So the outcome can be both positive and the negative. In the positive, we have that there can be the synergistic effects, whereas the negative outcomes, they are predominant because there are the adverse drug reactions and that leads to the non-adherence. Many of the drugs, they have effect on their pocket also, they are costly, and that is the reason in turn that leads to the non-adherence. So this is a vicious cycle that is created. Next slide. So what are the different control measures of polypharmacy? That is, first is the role of physicians, that he has to inquire about patients' medications and history, irrational use of drugs, and counseling of the patients. Next slide. So there are certain criteria that tell us that, what is polypharmacy and how to check upon that. So there is a base criteria. Next slide. Next slide. Next slide. I think you're going back, Pooja. Yeah, so there is a stop and the start criteria. That next slide. And stop and the start criteria, they are basically the screening tool of older persons' prescriptions and this screening tool to alert to right treatment. Next slide. Next slide. So there are various programs also. Please go back. There are various programs which are there. That is OPRAM, then Prima EDS, and the Sympathy Project. So next slide. So I'm just, because of the shortage of the time, so I'm just, I've just told you certain, sensitized you about in certain terminologies which are there in the polypharmacy. And one must be aware of all these. So not taking much of time now, I'm just heading to Dr. Arunanshu's talk. So Pooja, can you show Dr. Arunanshu's CV? Yeah, so we have with us Dr. Arunanshu. He is MD Medicine with University First Award from the University of Calcutta, India, and he's PhD from the University of California, LA, and he's the Fellow of the Royal College of Physicians, FRCP Glasgow, and he has many research contributions, and he's a co-investigator in longitudinal aging study in India, and he is a member of the ICMR supported research project evaluation committee. He has many national and international roles. He's an expert committee member of the drug controller of India, and he's an expert committee member of the National Program for Healthcare of the Elderly. And in the East Zone coordinator, he is of the Indian Academy of Geriatrics, and lot many in his bucket. I think we are running short of this speech, to tell everything about his, all the things he has achieved till date. So I request Dr. Arunanshu to please, enlighten more about the polypharmacy and the prescribing. Dr. Arunanshu, please.
Thank you. First of all, good afternoon, everybody, and especially thanks to Sanghamitra Di for inviting me and ordered me to have this speech in this IPHA banner. And I wanted to say, though I am a clinician, but I am also the life member of the IPHA. So it's also my association also. So I am very much thankful to Sanghamitra Madam to give me an opportunity to this talk. And also the Sonia ma'am, she also helped me a lot.
I think some other, this is also on, gadget is on in your room. That's why the voice is echoing. And I request all the members to please switch off their mic.
Yes. So already Sonia ma'am has prepared the stage for me regarding the polypharmacy and the deprescribing in what is the current scenario and what we can do as a public health expert in our country, especially and in the broader way. Can we have the slide, or you will allow me to slide?
So you can do it at your end, sir. That will be more convenient.
Can you just, yeah.
Okay, Dr. Pooja, can you do that? Otherwise?
Is it visible to all of you? Hello?
No, sir. Should I try? So should I send your PPT to my staff so they can do that?
Yes. Yeah.
Okay.
Then I have to stop sharing. Okay. Sure. Okay, let them to show my slides. So during that, I should not waste the time of because we are very running little bit late within our preparation. So what I plan to share with you regarding the polypharmacy and deprescribing today's talk. There are the two part of these things today's talk, mainly the polypharmacy and the deprescribing. And I will take you through a real case in our department, which we recently handled or the treated in a case of classic example, one of the classic example of the polypharmacy, how we see in our geriatric or practice of the senior care in our department. By the way, our geriatric department is one of the geriatric department, dedicated geriatric department in the Eastern India. It is the nodal center, regional nodal center for the geriatric care. So very often we are getting a lot of complicated geriatric cases as well as the classic cases as well as, and my whole team is working as a team effort. That's the most important part is a geriatric care. So if you can share the slide, ma'am. Anyone can. Yeah. So I will specially gone through the one of the case with you, real case, which I can tell you regarding this way. This is a gentleman of the 72 years old. He is a known case of multimorbidity like hypertension, diabetes, ischemic heart disease, as well as the Parkinson's. And so he is on this disease, all these four comorbid illness. That's why he is on the drugs for this disease. That's on the right hand side. I mentioned the amlodipine, metformin, glimepiride, Syndopa plus, clopidogrel, atorvastatin, and the pantoprazole, which is very quite common in the eastern part that for the hyperacidity drug, each and every prescription. Please go back to the slide. Let me finish that. So on that, but the patient presented with, along with these four comorbid illness, present with a district hospital, not in our hospital, with a high-grade fever, cough, and respiratory distress for the 3 days. So as he is admitted in a district hospital, they are considered it might be a case of the community-acquired pneumonia along with the multimorbid illness. So they started the IV antibiotics, nebulization with the bronchodilator and inhaled corticosteroids. And I told you what are the medicines he was taking. They are continuing. On top of that, they are on these 3 new medicine as soon as the patient was admitted in a district hospital. Next slide, please. So what happened during the day 2? So the day 2, they noticed that the patient becomes drowsy and the respiratory discomfort is continuously increasing. And the lab report shows there is a increased leukocytosis, elevated CRP, and blood urea nitrogen level. I can see the slide, ma'am. Please go back to my.
Yeah, Dr. Pooja, is there some net problem or what? So otherwise, if you have the presentation, you can just, carry
Yeah.
that.
Can I can let me.
Yeah.
Let's see. No, we can.
So I think, sir, this was your slide.
Okay. Sonam ma'am, is it visible now to your screen?
Yes, Yes, sir. You can just take it. Yeah.
Oh, okay. So shall I continue?
Yeah, sir. You can continue. The same slide has come again. So it is because of the network
Okay, no,
glitch.
no.
This is.
Yeah. So, so the on the day 2, so they have the patient having the drowsy and persistent respiratory discomfort, and the lab report showing the infection, chest X-ray showing the bilateral lung infiltrates. So according to curve 65, which we usually assess in our geriatric patient, curve 65 is showing the grade 3, more than 3. So that suggests that the patient needs more comprehensive management, intensive management. And ABG analysis also showed type 1 respiratory failure, HRCT suggestive of interstitial pneumonitis and urinary incontinence. So accordingly, they send the fresh blood and urine for the culture. So that is the day 2. But as the curve 65 is more than 3, they shift the patient from the general ward to the ICU in the district level hospital. So what the ICU specialist did on that patient, they upgraded the antibiotic in the injection piperacillin tazobactam in a renal dose, doxycycline, clindamycin. And additionally, as the patient is a very old patient and the bedridden patient, so they started the heparin injections and nebulization not only with the bronchodilator and inhaled corticosteroid as well as the glycopyrrolate, and also adding Montelukast levocetrigines. As the patient is developed AKI, so they are very much aware of this. So they stop the metformin and glimepiride and shifted to the sliding scale of insulin. So that's the classical treatment usually done in the any ICU setup in a peripheral hospital. But what happened? 3 days later, there is some clinical improvement, but his lab parameter, mainly the normalized, except the persistent kidney problem. The creatinine is rising still in the 2.1, hypokalemia, and uric acid level is 7.7. And urine culture report, sorry. Urine culture report is showing the suggested plenty of pus cell, and culture report is showing the E. coli. So they started another antibiotic, nitrofurantoin, flavoxate for spasmodic pain, febuxostat 40, and tamsulosin 0.4. And they also take the decision of the opinion of the nephrologist. He advised the sodium and torsemide. And from the sliding insulin changed to glargine insulin and linagliptin tablet. And also he has the low level of pot load. That's why they added the syrup pot load. But what happened in the day 4 in the ICU, the district level hospital? The patient developed psychotic symptoms in the form of irrelevant talks, wandering, visual hallucinations. So they the levodopa is tapered and risperidone 0.5 milligram added and lorazepam. But patient did not improve, still showing the restlessness, so agitation, so injection thiamine also started along with haloperidol drop. On the next day, they had to stop the risperidone and adding magnesium sulfate because there is a QT prolongation of the ECG. And also on the day 5, they found that the new onset of fever and also the lab parameter also suggestive of rising TLC, ESS, CRP, procalcitonin. So they detected this might be the case of new onset nosocomial sepsis, and the cultures were repeated. And as the patient is deteriorating, at this time, they referred the patient to our geriatric department for the special care. So this is one of the snapshot of our geriatric medicine department. As I told you, this is the dedicated for the senior people in our locality. So first thing what we did, the medication reconciliation. As usual, I am not going all the details. So he was more than 22 drugs at that time, which was started and was on that medicines initially for his long time comorbid illness. So that is the term of the polypharmacy, which is Sona madam correctly mentioned, the polypharmacy. Usually we call the polypharmacy when someone is receiving more than 5 drugs, and when someone is getting more than 10 drugs, then we call it a hyper polypharmacy. Is it common? No. It should be considered from the perspective of the patient's perspective. When a middle-aged adult, when they are having some problem, one morbidity like only diabetes or hypertension or the chronic kidney disease or the bronchial asthma, usually they have to take 1 or 2 or 3 drugs. But as the age advances, our physiological system is also deranged. So bioavailability of the all drugs, pharmacokinetics and pharmacodynamics of the drugs, which is also altered within our system in a geriatric population. And also there is a more inclusion of more morbid illness that in a geriatric population. So the doctor has to give more and more drugs, and not responding to one drug, they have to give more or 1 or 2 or 3 drugs for the one common disease, one single disease. So naturally, when any person almost going in the adult stage, most of them had to take multiple drugs for their multiple morbidity and their medical complexity, and due to their change in physiological process. So that leading to them taking 5, 10, 15, even 20, even 30 drugs in a day. I got many prescriptions having 30, 32, 35 drugs, especially right after the discharge from the hospital or the nursing home. So that is the question, whether this all drug is doing benefit or the harm more than the benefit. Because our target is not only the increasing the lifespan of any person. So that is not, should be from the health perspective. Rather, we should consider that our public health point of view, not only the increasing the lifespan, rather we should consider, we should concentrate much more on the health span of any persons. Because more or less, if we go to the statistics, almost each and every patient is on drug with at least 12 years during their lifespan. That means, but in Western country, they have the drugs with the multiple drugs only 3 to 4 years, because their health span is much more comparing with the health span of our country. So we should now think about that, which way you want more, health lifespan increasing or the health span increasing. And that is the role of the public healthcare system in our country. Because within this public healthcare system, this polypharmacy poses very several changes. And because of, I will go to no details, limited consultation time, fragmented healthcare delivery, lack of integrated electronic medical records, inadequate medication review mechanism, and can lead to the duplicate prescription, inappropriate drug use, and potential drug-drug interactions. So that, therefore, many elderly patients, also many patients, it is a common practice, they go to the doctor of their own choice, but organ-specific choice. Like they are going to at least 5 doctors at any point of time. We got many patients, like one for neurology, one for cardiology, one for respiratory, one for GI, one for orthopedics, one for diabetologists. So, and they, because here we have the, you have the right to go there. And that's why they are taking all the prescription and put them all together and picking up some medicine from here, some medicine, some there. And that is also one of the problem in our country regarding this polypharmacy. Ultimately, the consequences of polypharmacy among this older adult causing adverse drug reaction, leading to increased risk falls, cognitive impairment, and medication non-adherence, more hospitalization, reduced quality of life, and higher health costs. So all are the ill effect of this polypharmacy, where we are all responsible. And age-related physiological changes also affecting that type of absorption and distribution and the metabolism of these drugs. So we have to keep in mind when we are treating, when from the healthcare, health center, or as well as the tertiary cancer, wherever we are, we have to consider all these things. As Madam initially told, the prevalence of polypharmacy. Polypharmacy is not only highly prevalent only in our country, it is widely prevalent. In US, it is around 40%, 40 to 45%. In the European countries, there are very multiple studies showing that 25 to 40%. In the eastern part, mainly in the Hong Kong, Korea, that part, Taiwan, there is also 30 to 35%. So polypharmacy is not a problem of our country. It's a problem across the world because of this elderly population especially. If I go back, take some data from our polypharmacy in India, there are multiple studies done by our scientists or our the doctors or public health specialists in the different part of our country, and they have shown that the polypharmacy is quite prevalent in our country also. One of the most rural South India, there is a study among the diabetic patients. 84% people have the polypharmacy they found, and there are at least 4 to 8 medications they found. And national meta-analysis on the hyperpolypharmacy, they found that more than 10% medication they found in the national meta-analysis, they found that 1/3 of the elderly population, they are having the polypharmacy. So that's a lot, that's a huge burden of polypharmacy also in our country. So all polypharmacy are bad? No. Here we can demarcate between the polypharmacy in the two parts. One is the appropriate polypharmacy, another is the inappropriate polypharmacy. Definitely, if the patient requires the multiple drug, then definitely we have to give the multiple drugs. So prescribing multiple medications that are optimally tailored to meet an older adult's complex health needs. If it is necessary, then we have to accept it. Then it is called the appropriate polypharmacy. But if the patient is taking multiple drugs which are no longer clinically indicated, or there is a lack of clear benefit, or poses more risk than reward, then we can consider it as an inappropriate polypharmacy. That is the most challenging part here, how to segregate this, how to find out the which one drug is appropriate and which one is potentially inappropriate in that case, in that particular time of that senior people. So there, by that way, we can have a consensus that we have to reduce the drugs. That is called the deep prescribing. So deep prescribing is a eliminate the inappropriate drugs and accept only the appropriate drug for that person. Shifting from inappropriate to appropriate drugs, and that minimizing the adverse drug events and reduces the healthcare burden and improve overall outcomes of the older patients. It has been seen, it has been evidence-based findings. And this deep prescribing should be patient-centered. It should not be one shoe fit for all. Systematic process of reducing or stopping medication that may no longer be beneficial or may be causing harm. So it should be patient-centered and systematic process, not all of a sudden for one protocol for each and every senior people. So it should be patient-centric and systematically, slowly, thoroughly decision-making approach. So it should be a team method, and that can give us promotes the safer, more effective and goal-directed care by aligning medication use with an older adult's health priorities in our quality and their quality of life. So that's the most important part in the polypharmacy. We can detect, we can find out that the patient is having polypharmacy, but the next step is the deep prescribing, how to lower down the number of pill, how to cut the which pill I can omit from this patient's pill burden. So that is called the deep prescribing. So there are recently there are multiple studies occur and published in our own Indian scientists. The first one, the rational deprescribing practice in elderly patients, is an expert opinion by our leading different physicians and the public health specialists that is available online, this part. They opined that they already outlined the systematic approach to deprescribing, including the identification of potentially inappropriate medication through validated tools like the Beers criteria or stop and start criteria. And they also recommended the importance of the assessing individual patient risk, such as drug or drug disease reactions, before initiating any change to medication regimes. And the key component of this implementation of the patient-centered care model is the emphasizing the shared decision making between the healthcare providers and the patients. So this approach is expected to foster the better patient care and management. That is their conclusion in their paper. Next, I come to the another paper, which I am also the one of the co-investigator in our eastern part of the India. We did a study and published that the deprescribing based on assessment of the inappropriateness medication in our elder population using STOP and AGS Beers criteria. It was a multicentric longitudinal study. And there we recommend that this study shows us the critical utility of structured evidence-based framework like the AGS or the STOP criteria guidelines in identifying and mitigating inappropriate prescribing practice among the elderly population. So we can say that deprescribing, when systematically implemented through multidisciplinary collaboration, represents a pragmatic, efficacious, and patient-centric strategy to optimize the pharmacotherapy and geriatric population. So our findings advocate the integration of deprescribing protocol into the routine clinical practice and the national geriatric health policies that we advocate and that we suggest to our health policy makers. So here is the role of the IPHA, that how can we do this, because still now there is a no public policy from the government of India, so if they can do. The third, recently finished this study is the ICMR initiated multicentric study. As here I am also the one of the PI. So we developed and validated deprescribing tool considering our Indian scenario, because Beers criteria, AGS criteria, they only took the modern medicine. But here we also found that there is, apart from this, the patient took non-modern medicine like Ayurvedic medicines. Also, we have the tendency to fixed drug combination tools. Also, the over-the-counter medicines. These are not incorporated in the Beers criteria or the stop or start criteria when they are doing these things. So these are the challenges, newer challenges which we faced in our Indian scenario. So we use the modified Delphi consensus technique and we developed a deprescribing tool considering these newer challenges, innovative, I could say the new challenges which we found in our Indian context, that the drug groups commonly prescribed relevant for the older patient in India, including herbal and drug interactions restricted to drug available and prescribed in India. We developed this, and I also requested ICMR to submit it to the government of India to take this way forward as a public health policy. That these are also the challenges in when we go for the deprescribing techniques. So these are the three studied. Apart from this, there are multiple other studies. I am not going to the details and much more this. But most of the study in our country, what we found that these are the barriers of the deprescription. The barriers are the three level. The patient level barrier, they have an uncertainty and the fear. Whenever you wanted to change anything, no, doctor, I am fine with my previous drug. Why do you change it? Lack of health literacy. Believe it or not, there are multiple studies showing that 80 to 90% of our Indian population has lack of health literacy in our country, and especially the rural people. And we have the patient and their family members have already a preoccupied, predetermined mindset regarding the disease control mindsets, not from the preventive or the promotive aspect. I have a heart disease, so definitely I will go to the heart specialist and I will take the drug, whatever he prescribes. Okay, I have a neurological problem, I will go to the neurologist and will take this drug. So this is already an established mindset. These are the barrier to implement the deep prescribing from the patient's perspective. What is the barrier from the clinician level? There are many surveys done. The most important thing is on notice that the lack of training and the awareness about this deep prescribing tool and the polypharmacy hazards of polypharmacy in the clinician levels also. Apart from that, they have a very fear of adverse consequences because they thought that if I stop these 4 drugs, if the patient not doing well, they may shift from me or they may have a bad comment around me. So so they wanted to begin, okay, they remain the status quo in Shasha. Okay, leave it. What he's getting, let them continue. And as I told, the fragmented care, there is very minimal team effort or multidisciplinary approach is still lacking in our country. And the last but not the least is the time and resource. If you all know that how much is the patient overload in our government sector hospital, so how much time we can devote for each and everyone, definitely that's all. If I have anything in our mind, but we can't do due to the lack of time. So patient level barrier, clinical level barrier. Now the system level barrier, definitely. We have the tendency from the policymakers, from the administrator, that the prescribing focused culture, how much prescription done by this doctor. So individually, so one patient going to multiple department and then the administrator thought, oh, okay, I have the 2000 patients, 2000 prescription today. So this prescribing focused culture, this is also a barrier for deep prescribing attitude. And sorry to say, all the guidelines in our drug guidelines, medication guidelines, usually single disease guidelines. For the diabetic patient, diabetic management guidelines, hypertension management guideline, bronchial asthma patient, all are, be it in India, be it in the world scenario, all are single disease guideline. But the geriatric population, they are not only the one disease in their body, they are having the multi-system, multiple disease in their body. But very minimum guideline, very few guideline are talking too much, many things about when one diabetic patient's having the neurological problem, having the hypertensive disease, having this osteoporosis, then what should be the drugs? What will be the hypertensive management when someone having the COPD? So usually these are not well delineated in our single disease guidelines. So this is the limitation. We definitely follow the guidelines, but this is the very much problematic when we the doctors are taking care of the senior peoples. And most of the drug trial are usually done in the adult population, 18 to 60. And we extrapolated that findings to the geriatric population. But I told you, the metabolism, pharmacokinetics, pharmacodynamics are much different in the geriatric population. So only extrapolation cannot be accurate when we are recommending any drug in a right dose, in a right time. So these are to be taken care in the system level. And fragmented healthcare, that I told you, we have the lot of, in our medical college, we have now 42 disciplines in our department in our medical college. So if we can have one common place where each and every specialist can sit together and decide this one patient's that how to handle these things. So if it can be done, then we can discuss back and forth that yes, these drug can be given, these drug cannot be done, like a board usually do for a very limited patients. But if that can be done, then it can be probably important. And the last but not the least is the perverse incentives. We have the incentives very much. If you can prescribe, if you can see 100 people in a day, then you will be getting incentives. In a pharmaceutical industry, giving more incentive for prescribing different kinds of drugs on their own. I can share with you one example of the cobra incidents. When during the British Raj, when there is a huge cobra snake in Delhi, they announced that those who can kill one cobra, they will be getting incentive, they will be rewarded. So apparently it looks like, okay, it's good. So there will be the elimination of the cobra snake in the Delhi capital. But what happened really? Those who are the poor people or the other people, they try to breed many cobra and then they kill, and going to the British Raj, they're getting the some funding. Ultimately, cobra elimination was not possible by this reward, that getting a reverse way, more cobra snake during that people. That is a classic example from the history, and it is still going on in our healthcare practice, in our private practice, or in some other way in the different. We are getting more incentive for the drug promotion, but ultimately it may be harmful to a patients when they're giving more drug, multiple drug in irrational combination. But there are some facilitator in the deprescribing. Definitely not only the barriers. If we have the strong clinician-patient communication and shared decision making, if we can take our patient and their relatives in a decision making platform, then we can describe and can explain this. There is a lack of educational support and the clinicians and the patient both. If we can develop this educational support regarding the polypharmacy, hazards of polypharmacy, and involvement of the family and the caregiver in the management team. And definitely what I told, it should be a multidisciplinary teamwork. And if we have the electronic record system, so immediately I can access what the patient is getting from the other doctors. So, and they can also share, they can also see my process. If we can have this electronic medical records and easily available all the details of the patient's prior illness and all these things, that can also help us facilitate these deprescribing tools. And what I told you, system level enablers. Yes, if there is, we have the policy, if we have the strong will in the government sector, in the policymakers, then we can definitely conquer this and we can go for the deprescribings. So it's a balance between the barriers and the enablers during our deprescribings. So definitely we have a lot of barriers, and definitely the hoping sides that we have a lot of good enablers in our situation. So we have to much more focusing on the enablers. If you can encourage these enablers, definitely we can go down these barriers and we can have a good drug prescribing policy in our country also. So how can you do this, the prescription? First and foremost thing is the medication review. Whenever you will get any patients, go for all the medication which is getting, not only from the prescription, out of the pocket, over the counter, herbal, anything. So jot down this and try to put it in a one page. What are the medicines and which are inappropriate, which are appropriate. And then you talk with your family persons or the patients that see, these are the problematic drug. I wanted to delete this, I want to omit this, I want to this. You discuss with them. And for this, you need the healthcare professional training, where IPHA can take a more responsibility, that the training of the healthcare providers, and also developing the patient-facing educational materials, not only from the doctors, if it is widely circulated, widely awareness generation among the patients, that and the definitely involvement of our caregivers, of our formal or informal. They should also know the hazards of this family planning taking. So now come to back to my case, original case that I told you, shared with you. So what we did in our reconciliation, you see, almost 31 medications he was receiving when he is one in our geriatric population when she admitted. So all of this, so Sindopa, or for the, it is usually not recommended in the acute care setting. Benzodiazepines, antihistamines, we stopped, and the patient is already catheterized, no need to have giving tamsulosin, flavoxate, we omitted, and other medication less not indicated like the torsemide, Maxal, and N-acetylcysteine, and vitamin C. We thought this is unnecessary medicines. So ultimately, we delete that and we keep these medicines for these patients. These are the few medicines we keep, and the rest of the things we stop these medicines. So in that way, after medicine reconciliation, we come to these medicines only. And why do you did this? Because we all know that the syndopa, usually it may precipitate the psychotic symptoms in ICU setup. And for that psychotic symptoms, they use the risperidone for the acute psychosis. For that risperidone using causing QT prolongation. For QT prolongation, they uses the magnesium salt. So if syndopa is not a acute emergency drug, so if we can omit, then we can stop magnesium, risperidone, and the syndopa. Similarly, for the cough and LRTI, no need to give the antihistamines and benzodiazepines because they cause the much more drowsiness and increased risk of delirium and fall. So, and they are leading to a delayed recovery and the more hospital stay, more hospital acquired infection chance. So ICU psychosis, delirium, and its complex interaction with geriatric syndrome leading to frailty and cognitive decline. We should keep it in mind every time whenever any geriatric population are admitted in an ICU setup, and we should stop this kind of medicines as long as they are in the ICU setup. So what happened for these patients? So psychotic symptoms gradually improve over 2 days. We can easily stop the haloperidol, and non-pharmacological interventions like the environmental modification, family involvement, communication, reassurance, and psychologist consultation. And after 5 days of the meropenem injection and latest culture sensitivity, fever subsides, and we also normalizes all the parameter, and AKI also improved, catheter also we omitted, and mobilization, we started the early mobilization and chest physiotherapy, and within after 7 days of the antibiotic, we discharged the patient only with what the patient was getting: antihypertensive, antidiabetic, and ischemic heart disease. And we restart the syndopa after 3 weeks in a lower dose and gradually escalating the dose. So this case underscores the risk of prescribing cascades, which Shona madam told us, the prescribing cascades in the elderly ICU patients, which can exacerbate adverse drug reactions and that complicated the recovery of the patients. So, I can say that the polypharmacy is an increasingly important issue in India's aging population. Strengthening medication management within the public healthcare system is crucial for ensuring safe, effective, cost-effective care for the elderly individuals while supporting the broader goals of healthy aging and universal health coverage. So, inappropriate polypharmacy is a challenge, public health challenge. Deprescribing is a safe and effective method of managing this issue, and deprescribing is a complex procedure, so we need a team approach. And there, as we know, we are aware that significant barrier like time, education, and fear of adverse effects, but still we can do these things. We need a collaborative, multidisciplinary approach with the open and effective communication within our team as well as the patient and their family persons. Thank you for your kind hearing. This is my team geriatric medicine of our medical college in Kolkata. Thank you so much.
Thank you, sir. Thanks a lot for such an elaborative talk, and it was substantiated by various examples. But I can very well understand that in short span of time, all the aspects cannot be taken. So that's why after seeing your presentation, I just added a few points which I felt that everybody should be sensitized about. But it was very nice talk. We have with us Dr. Kaushik also. He's a Secretary General IPHA. He has just joined as he was traveling. So I request sir to say a few words.
Thank you.
Sonia, just a minute. Dr. Sonia, There are some questions for speaker.
Yes, ma'am.
Please refer those questions to speaker and just explain those.
Right, ma'am. So, Dr. Pooja, can you just take up few of them so that sir can answer?
Good afternoon, sir. Thank you so much for the insightful session. The chat box is filled with questions, as we can see. So, first question is, what can be the strategies to improve medication adherence while simultaneously reducing unnecessary medications?
That's a good question. Definitely. You know, the practical point of view, as we are working in an Indian scenario, we are not in the Western country. Those I have a educational background in the Western, but I can compare these. We can have that luxury in our country, definitely. But within our limited resource, if we have a proactive mind and a background knowledge of this polypharmacy and deprescribing tools, if we sit together, if we can take all the doctors who are in consultation for the treatment of that particular patient in a on board and discuss within ourselves, because many a time we got that the cardiologist is giving AC inhibitor for the heart failure, and for the same the renal compromise, the patient is getting the ARB, angiotensin receptor blocker, but the action is the same. So, but as the trade name is separate, then the action is in the different point of time. Ultimately, patient doesn't have any fruitful action. So, if we can sit together, as well as also not only the doctors, as well as the other team member, pharmacists, nursing staff, physiotherapists, it's possible. It's possible. We can start it this. Then and then we can reduce this pharmacy burden, polypharmacy, and the healthcare cost in our country, and also healthy life. As I told you, the health span increasing that we can do. We can start, then we can see what are the challenges coming in the next time.
Thank you, sir. Another question is that to what extent can developing fixed dose combinations tackle polypharmacy? Can FDCs be a solution for polypharmacy, or the risk persist?
Yes. Fixed dose combination is usually not recommended until there is a compulsion, like in HIV, which is 100% compliance is necessary. That's why government has a policy to have this fixed dose combination pill, FDC pill, like HIV, even in the tuberculosis control, because that's a necessary for the 100% adherence. But what even I found recently, but the government also said, painkiller NSAID with PPI in a FDC. This is irrational. So we have now as a time to consider to have a policy that what kind of FDC can be allowed in our country. That is the public health expert in this forum. So I can request all of you to talk with the DCGI that whether this is at all, there are irrational fixed dose combination is widely prevalent in our country. That I told you, the pervasive incentives that they are getting. So their market is, their sales is increasing. So we should have a policy that these are the FDC only allowed and only to be marketed, and the rest of the FDC should be banned and should be taken out from the market. So that can be done with the help of our association to the negotiation with the DCGI.
Right, sir. Thank you so much. Another question is that there are many medications which are very commonly prescribed in elderly people, but they can be a potential drug which can be de-prescribed. So can you suggest or can you enumerate some drugs which are commonly prescribed, but they can be de-prescribed easily and would not have for say much effect on the health of the elderly?
Yeah, that's a good question. Usually my PGT is asking. So the most of the one of the important, the hypertension, diabetes, COPD, these are the common problem. So I would suggest try to avoid the diuretics in the elderly people. If not, as long as possible, definitely anti-diabetic, diuretics is one of the pillar of the antihypertensive management. But the physiological changes of the electrolytes is very dramatically changed, dramatically altered in the elderly people. Most of the time, believe it or not, we got the many stupuras patients. There's having this altered sensorium due to hyponatremia, and the patient is on the antihypertensive, the diuretic, having some vomiting with a little bit of 1 or 2 times of vomiting, they are having these things. Similarly, the antidiabetics, which is causing acute hypoglycemia much more, like the sulfonylurea groups, try to avoid that group of drugs, because in elderly people, if you can ask me, we would recommend little bit higher zone of, that is also recommended in the diabetic management guideline, higher level of the blood sugar level, but never allow to hypoglycemia, because they are more prone to having the hypoglycemic with the sulfonylurea groups. If possible, avoid the sulfonylurea group of drugs in the diabetic patients. Like similarly, the sedatives and also the other sedative like painkillers, try to avoid this, because risk of fall is much more with the sedative pills. And the prevention of fall is one of the most important problem in our strategy, in our day-to-day practice, because one fall lead to the multiple problem in their lifetime. One fracture neck femur, or one fall fracture of the shoulder, in these things. So always we think about the how to prevent fall, and one of these is the try to avoid the sleeping pills. These are the example I told you, and we can have them much more, but these are the 3 important we usually very much concerned about not to use, or to try to avoid as much as possible.
Right, sir. Thank you, sir. Sir, another
Dr.
question.
Pooja?
Yes.
Yeah, I think we can, because it may stop at any time, our link. So now
Mhm.
I request Dr. Mitra, Kaushik Mitra, to say a few words, and then thanks a lot. We can just say thanks to all the faculty and the speakers also. I'm just worried for this link to stop. That's it. Yeah, Dr. Kaushik, please.
Thank you, ma'am. Good afternoon, all of you. Uh, Today we have with us our president, ma'am, Dr. Sanghamitra Ghosh, also with us. I have listened, but I cannot listen continuously because of the poor internet connection. I was traveling, but still it is a very good discussion today regarding polypharmacy and deprescribing in the elderly. Polypharmacy is really a public health problem nowadays. And Sir, Dr. Urbangshu Talukdar sir has vividly described the impact of this polypharmacy and this deprescribe in the elderly, and through better medication management and practical strategies and safer prescribing practices. So thank you, sir, for being with us, and thank you, Dr. Sonia Puri ma'am, for arranging such a good webinar as a part of the community geriatric series also. And I also thank our president ma'am, Dr. Sanghamitra Ghosh, to be our inspiration regarding this program. Thank you all the participants who have attended the program. Thank you all.
Thank you, sir. And I would like to thank our IPHA president.
And one more, I also thank our IPHA Chandigarh branch, our president, Professor J.S. Thakur, for arranging this. Thank you.
Thank you, sir. I think there are so many people who have joined and made this venture a success. So my heartfelt thanks goes to Dr. Sanghamitra Ghosh and to Dr. Kaushik, and of course to our worthy speaker, Dr. Arunanshu. And of course, I think if there are no participants, so the talk is always never fruitful. So we had a good amount of participants, but I think now slowly they have just left this. But I thank to all the participants and all the faculty who made an effort to join and who prompted their postgraduate students and the other faculty members to join this. And I think it's a very good platform because geriatrics is a branch which is not given, till date it was not given so much of emphasis, but now it has, it has come into the limelight, or you can say now it is the need of the hour because of the demographic transition and also because of the epidemiologic transition. And I'm very much open to all the collaboration that Dr. Arunanshu was mentioning, and our institute would be very keen, in case of any of the collaborative studies, if it is desired, or if we can just be a part of that, we are will be very thankful for that also. So I think in end, I would also thank my team, all my postgraduate students, Dr. Pooja, Dr. Rupali, Dr. Deepak, and there's so many, and the like other project staff, for making it a success. They were always there with me, and they were managing the whole show. And all the doubts which have been, unanswered till now because of the paucity of the time, I think we can take them over later on, and in a way that they can just always mail, or we can just, mail to sir also, and whichever we can sort at our end will do. Otherwise, then sir can take up. So with that, I I pay my thanks thanks to everybody. And if ma'am and sir has to say, I think they can just go ahead. Yes, ma'am, would you like to say something in the end?
No, no, it's just thank you to all, and thank you to Dr. Arunanshu. Though in his busy schedule, he can manage the time. And Sonia, wholeheartedly you helped. And we'll take this over to the next few months, this community geriatrics. So we'll meet again, I think. And thank you so much. Thank you,
Definitely,
the
ma'am. Definitely.
participants.
Thank
Thank
you.
you,
Thank you.
participants who have
Thank you. Thank
taken
you.
that time. Thank you. Thank you all.
Yeah.